Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a relatively recently described entity, the Adamantinoma-like Ewing Sarcoma, this time occurring in the parotid gland. So this is a case of a 54-year-old female patient who was complaining of right parotid gland swelling. And as you can see here from the low power magnification, there is an infiltrative tumor. This is extremely important. Infiltrative tumor that is blue in color. So it is like a small round blue cell tumor, and these are important clues to the diagnosis. On higher power magnification, as you can see here, it's a kind of embryonal tumor, a small round blue cell tumor with many mitotic figures scattered around. And as you can see here on another focus, where you can see some tendency at rosette formation, but in general, we have a tumor that is composed of a proliferation of small round blue cells with high NC ratio and mitotic figures scattered here and there. And again, here another focus. There isn't, I have to say, much of peripheral palisading, which is sometimes described in a subset of these tumors. And what is also described in a subset of these tumors, but not in the head and neck tumors, the presence of abrupt keratinization, which tends to be less often described in head and neck tumors in comparison to tumors occurring elsewhere. However, what is really important and well described in this entity in the head and neck is the presence of hyalinized stroma in between the tumor cells. And this appearance actually and the location of the tumor would raise a number of differential diagnoses, including different types of malignant salivary gland tumors like myoepithelial carcinoma, for example, or basal cell carcinoma, or even unusual tumors like neuroendocrine carcinoma, small cell carcinoma, or even desmoplastic small round blue cell tumor. However, it's very important if you have this diagnosis or differential diagnosis in mind, which is the Adamantinoma-like Ewing sarcoma, you will order the proper immunohistochemistry and you will reach into the right diagnosis. So number one immunohistochemistry is CD99. Remember that this is a subset of Ewing sarcoma, and because of that, CD99 tends to be positive in these tumors, as well as a nuclear staining for the NKX2.2, extremely helpful, of course, to support the diagnosis. However, if you do not think of the entity, you will not order the proper immunohistochemistry, and so you will not reach into the differential diagnosis or into the final diagnosis. But what is also needed to support the diagnosis is a positivity with P40 in the tumor cells, very characteristic in combination with the previously two mentioned immunohistochemistry as well as Pan-cytokeratin. So Pan-cytokeratin, P40, CD99 plus minus the NKX really needed to reach into the differential diagnosis and to sort out the other differential diagnosis that I mentioned at the beginning of the video. Now, synaptophysin can sometimes be positive in a subset of cases. This is helpful to support the diagnosis. However, this is not needed to confirm the diagnosis. You should always order S100 to rule out myoepithelial carcinoma. S100, smooth muscle actin, or calponin are needed to rule out the other important differential diagnosis, which is myoepithelial carcinoma. And desmin is needed also to be ordered and needs to be negative to rule out a number of entities, including, for example, rhabdomyosarcoma and desmoplastic small round blue cell tumor. Now, in order to confirm the diagnosis, you have to ask for some sort of molecular confirmation, either by molecular testing or by cytogenetics, for the EWSR Fly1 translocation, which was positive in 100% of the tumor cells in this case. So the final diagnosis for this case is Adamantinoma-like Ewing sarcoma. This is a subset of Ewing sarcoma that shows, in addition to CD99 positivity and the NKX2.2 positivity, cytokeratin positivity and P40 positivity. And this is why it has have the quotation of Adamantinoma-like because it shows it's a sarcoma that shows this cytokeratin positivity. Usually it occurs in the head and neck region, in particular in the salivary gland area as well as in the thyroid, but it's also reported in other locations, different areas within the bodies and soft tissue compartments. A recent case was reported actually in the pancreas. It is composed of proliferation of a small round blue cell tumor that brings into the differential diagnosis a large number of entities. However, if you have the combination of CD99 positivity, P40 positivity, as well as cytokeratin positivity, the three of these can support the diagnosis. You need to order other immunohistochemistry like S100 and desmin and smooth muscle actin to rule out the possibility of other differential diagnosis, especially in the head and neck area. And of course, confirmation by cytogenetics in particular is extremely helpful in reaching out into the final diagnosis. In the caption, I have the link to a review paper that talks about Adamantinoma-like Ewing Sarcoma with literature review. I hope you find this tip useful in your daily practice. Thank you.